I think I'm going to start with introductions. To those of you that don't know me, I'm a pathologist at UAB. I've been here for 25 years, and I'm the current president of the UAB chapter of the American Medical Women's Association. So AMWA is open to everyone, and we have been doing several Zoom sessions in the last year since the pandemic that have allowed for a lot of people from all over the campus and even outside of UAB to participate, which has been very, very reassuring and fulfilling. So we've had several sessions on different topics, like the last one on June 1st was on looking back at medical school and residency. We've talked about infertility. We've talked about how to present in front of an audience, how to manage stress. So normally we have these sessions once a month. But because we are not planning to have one in July or August, and because June, this month we celebrate or we remember 40 years of AIDS, I was very happy that Dr. Saag and Dr. Eaton and Dr. Elopre accepted to speak to us about the AIDS epidemic and what they've done for it. Because the speakers today are so accomplished, and and Jessica put the links to their biographies in the invitation. I'm not going to go into that because it would take most of the hour, and we have great people to listen to. But I want to point out to all of you, if you haven't read this book that Dr. Saag published a few years ago, that you should look for it. I'm going to read it again because I think I forgot some of the details, and it's unbelievable to hear how someone that we still work with and part of our community has been involved with AIDS for this long and has done so much as Dr. Saag has. So the plan for today is for him to start telling us giving us an overview of this terrible epidemic that we're still suffering from. Then Dr. Eaton and Dr. Elopre will discuss with us what they have done in the study of different aspects of the HIV epidemic. So I'll let Dr. Saag share his screen, or Jessica, and we'll go from there. Thank you so much for being here.
Great. Can everybody see the screen?
Yep.
Where have we been?
Yeah, perfect.
Great. Where have we been and where are we going? This will be about, maybe a 15-minute overview. So these were the famous MMWRs. The first one on the left is from June 5th, 1981, over 40 years ago. And then another follow-up one, 1981. And these were the first cases of AIDS as we know it. And these were initially pneumocystis and then Kaposi among gay men. And the thing I'm going to come back at the end of the presentation and reflect on similarities and differences between COVID, which is the pandemic that hit us in our lifetime, at least my lifetime. And I think you'll be surprised at differences. But what I'd also like as we go through this presentation, pay attention to the dates as they go by with the AIDS epidemic. So June 5th, 1981. CDC was right on the case. They sent out people like Harold Jaffe and Jim to go to Los Angeles and San Francisco and New York and Miami and Atlanta to interview cases of people who had this and trying to come up with a case definition so they could describe this peculiar set of symptoms that were occurring in young, otherwise healthy gay men. And initially there were a number of names for this, from GRID to gay-related immune deficiency. and then ultimately to acquired immune deficiency syndrome as we know it as AIDS. February of 1982, some 8-9 months after the first cases, and they started having more reports of OIs and what we then called OIs, opportunistic infections, and Kaposi's sarcoma. And they ended up using this case definition just for KS and PJP or PCP at the time. You can see the cases going back to 1978. So it was brewing for at least 3 years, probably longer in the United States before it got reported. And that led to the concept that by the time the patients presented with what we know as AIDS, the data started to show that that was just the tip of the iceberg and that there were a lot of other conditions before an AIDS defining condition hit that were precursors of what they were to see with the AIDS syndrome. So people might have thrombocytopenia, or they'd have lymphadenopathy syndrome, or some degree of thrush. Those things were not AIDS defining at the time. And CD4 counts were just coming into play. So those weren't case definitions. That wasn't really until 1992, 93 that the use of CD4 count below 200 was part of the AIDS definition. This is Jim Curran, who is, I think, one of the true heroes of this epidemic at the time. And this is a meeting at the blood bank. And they were having a discussion about whether the blood supply was safe. Now, note the date, 1983. This is about 2 years after the syndrome was first described. And the blood bank industry pushed back very hard against the notion that this was a blood-borne transmitted disease. And the reason that, part of the reason that they were concerned was that it would create panic and it might threaten the blood supply to the point where they wouldn't have products to give to people. And it led to a lot of consternation. And this was Jim's quote at the bottom in circle in red. I'll read it to you. "Very depressing," said Jim Curran. "We spent most of the time trying to convince the blood banks it's transmissible. We think there's no question,
No
but
doubt.
they want more. They want more data, and we plan to provide just that." This is the concept of transmission. This is a patient named Degas, Guton Degas, who is a Canadian air flight attendant. And what they're showing here is in the center circle with the red bar, that's Degas. And then around him are the cases of people that he had had sex with and who became infected. And then the color codes are the type of infection. So white would be pneumocystis, and yellow would be Kaposi's, and orange would be some other OI. And the take-home point is that this just shows and underscores the point that all transmission is local. We can follow epidemics as much as we want, and that's looking at populations. But at the end of the day, it's a person next to another. Now we know through sexual transmission or through contaminated blood products or sharing needles, but it's one-to-one. It's always one-to-one. After the case definition was created, AIDS was defined, this is how the exponential growth of an epidemic happened. This was a slide that I believe Jim Curran showed at, this was the Cool Font project in May of 1986. And then in June of 1986, the same slide was shown at the Second International AIDS Conference in Paris. But what you're seeing here is that where the white lines come in at about early in 86, that's where the real data ends, and all the green bars out to the right are the predictions of what they would expect to see over the coming several years, the coming 5 years. And what's remarkable is that the predictions were remarkably accurate. Predicted this with great confidence because they had figured out the transmission pretty well. 1983, now that's 2 years after the first syndrome cases were defined. the causative agent was identified more or less simultaneously in Paris and in Bethesda at NIH and at the Pasteur Institute. And this was a game changer because this finally nailed down what caused HIV, that it was this virus. At the time, the French called it lymphadenopathy associated virus, and the US folks called it HTLV3 because it was in Gallo's lab where he had defined HTLV1 and later HTLV2. So this became the third in line of the human retroviruses. All of this is summarized in a book by Randy Schultz, and the band played on. If you want to read about the history, I will sort of give you a little bit of a reader's commentary or editorial comment that this is a very readable book, and the stories are accurate. I'm not going to question that, but the narrative of it is quite dramatically spun in a way where the heroes are made out to be superheroes and the villains are supervillains. And it really was, but he was sort of put down in this book as an evil guy, as Satan of sorts. And then on the other hand, some other folks like Don Francis was made to be a superhero, and he wasn't quite that. But if you sort of attenuate that, it's a pretty good chronicle of what happened. Now, meanwhile, at the National Cancer Institute, just down the hall from where Gallo's lab is, these folks, Bob Yarchwin, who, by the way, is still at NCI, Hiroki Matsuya, and Sam Broder, who later became the leader of the NCI and moved out west to, I think it's Stanford. But they started scouring through medications that were already on the shelf in the form of nucleosides. They discovered that 3'-azidothiamidine, which you can see in this upper right panel. Notice that this is a thymidine analog and ribose. Instead of a hydroxy group being there, there's a substituted azine, because remember that chain propagation of so as that 5' hydroxy group in the ribose connects in chain propagation, the azido group in that building block blocks any further propagation, and it causes chain termination. And that was found to work very well. And you can see down below, there's 2', 3' deoxyadenosine, and there's some other dideoxy compounds that we also learned as DDI, DDC, and the like. So this was a state of treatment around 1988. If you've met how people's lives were dominated by when they took their AZT, if you remember in Viva la Vie Boheme at the end of Act 1, their beeper goes off and Mimi says, AZT break, and then they would pop their pills. And in retrospect, we were overdosing AZT, not intentionally, but just we were giving it way too often, had a fair amount of toxicity because of that. But this was almost a meal for some folks by the time they got to more advanced stages of HIV. They had a meal worth of pills.
Some people may not realize, excuse Mike.
The critical role of the activist community. Yeah.
Your video is sometimes
yes,
less than optimal, so that's why some people may be wondering why your audio is like that. So it's for the most part we can understand.
Lagging.
Yeah, a little bit, and then you're frozen right now.
Okay, we could. Okay, sorry. Okay. Well, let's give it a minute. We could always switch over to the home crew, and I can audio So maybe we'll take a quick break, and Jessica, if you want to bring up, I'll stop sharing and I'll talk about this. As wrote The Normal Heart, and he was a real hero to me. He was really short, and he used fear, and that fear is what drove motivation of others. And we're going to contrast later how the activist community in COVID is a little bit different than the activist community was in the HIV era. Next slide. Are you all seeing the next slide?
Mm-hmm.
There we go. And so their concept was silence equals death. They founded the ACT UP, and this was their messaging to Washington. I will say that in the interest of time, I won't go into a lot of detail, but the administration from 80 to 88 did never mention the word AIDS once, never came out of the mouth of the president. There was some response in 1984 and 1983 when the virus was discovered, but the president never gave a direct address on AIDS, despite the fact that several thousand people in the United States have died of it. Next slide. And this is just another example of how the activists were trying to spur on people. Marty Hirsch is a great human being. And behind the scenes, he was working his tail off to help people. And it wasn't being perceived that way by the activists who saw friends dying. Next slide. Okay, this is Ron White, who was from Cicero, Indiana, 13-year-old with hemophilia, that the Ron White Care Act was passed. And this is the moment on Capitol Hill when the Ron White Care Act was passed. He died just a few months later. Next slide. So science is really what ruled the day. Next, hit it again. And this was an example of how a study that came out of UAB showed that, unlike other retroviruses, HTLV-1, for example, there wasn't a latent period. That we thought that there was a virologic latent period, but there really isn't. And we showed that viral replication was present throughout the entire time once someone was infected. And that was a major contribution made possible by the development of quantitative PCR with Mike Piatek and Jeff Lifson at Gene Labs. Next slide. We also went on with this one slide to show the rapid turnover of HIV, where just from this one slide, we determined that there was 1 to 10 billion viruses produced a day, and that they lasted on average about a day before they were replaced by another virus. And this went on, this churn of 1 to 10 billion viruses a day is how HIV causes its pathogenesis. Next slide. So now, next slide, I hit it again. Now we're seeing that we went from a handful of pills to a single tablet, about 2009. And just to close out.
We just lost you.
We now have single tablets that are very potent, that once someone gets on treatment and they are able to take their medicine every day, they will lead a normal lifespan and they will not transmit the virus to others. And that's kind of day. And over that 40 years since the first cases, this is how we ended up. Next slide. To the point where now we're hoping for the end of AIDS. And so I'll close there. That's going to be done through sort of 90-90-90 concepts, where we identify 90% of the people who are infected, get them into care, 90% of them get on treatment and are suppressed virologically. So I'll close there and turn it back over to you, Maria.
Thank you so much. This is amazing. Thank you. And we appreciate you joining us from your vacation place in North Carolina, which is why the audio is affected. The next speaker is Ellen Eaton. Ellen is an assistant professor in infectious disease, and she's going to talk to us about her work and in the budgetary impact of these treatments for HIV. So it was perfect segue where Mike was talking about the current treatments. And so, Ellen, as I mentioned in the beginning, for those of you that were here, all three of them are extremely accomplished individuals and have very interesting stories and backgrounds and lots of experiences. So, by all means, click on the link that Jessica sent to read more about them, so we can take the time to listen to them. Thanks, Ellen.
Thank you so much. Can you all see my screen now?
We can.
Great. Okay. And so I apologize, Dr. Marquez. I included more on opioids and the template that HIV has allowed us in treating opioid use disorder, but I'm happy to come back another time.
Oh, that's fine. No, that's fine. No problem.
Okay, great. So I'm so glad to see you all on the call. This is something that's very near and dear to my heart, and something that we all need to raise awareness for, which is the opioid epidemic. And I just wanted to use this opportunity to take a few quick takeaways from what we've learned, what Dr. Saag has taught us about, and how that can help us really tackle the opioid epidemic at a large scale and at the patient level for those of you that see patients. So I do lead the opioid treatment clinic at 1917. So I see some trainees on the call, and I'd love for you to shadow and come see the work we're doing there if you're interested. And sorry, let me get this. I apologize. Okay. All right, so the first thing that I want you all to think about as a takeaway from HIV that we can apply to the opioid epidemic is that this is a fatal epidemic. We know more people have died from the opioid overdose crisis than did during the whole HIV/AIDS epidemic, which is really just staggering. And we know that just like HIV, we're learning a lot about the host. Patients who inject drugs specifically, but really all who use illicit substances are at risk for opportunistic infections. And with HIV, we learned about pneumocystis and all these other exotic infections. And we're learning that patients with substance use are also prone to a whole range of infections. So I am just going to walk you through that first lesson as a framework. Unfortunately, in the news, we continue to see a lot of young men overdosing just like HIV. These two stories I'm showing are just in the last 2 weeks. There were 2 paratroopers that overdosed with what's thought to be fentanyl right up the road at Fort Bragg. Young men, really in the prime of their life. And the second story is close. It's in Irondale. I don't know if you saw a local car dealership. 2 men were found in a storage workspace. Initially, we saw no foul play suspected. And of course, I thought, fentanyl, just with what I'm seeing in my practice. And it does sound like fentanyl and meth together led these 2 local young men, 40 and 34-year-old men, to pass away from the opioid epidemic. So it's really a crisis, and it is certainly very fatal for our patients and our community. And then thinking about opportunistic infections, again, any illicit use, but certainly injection drug use is causing a crisis of these unusual infections, things that we shouldn't see in 30-year-olds. We should not see endocarditis in 30-year-olds. We should not see vertebral osteo and brain abscesses. And what I'm showing you is a cohort of hospitalized patients who inject drugs across 4 sites. This is a choice study. This data is unpublished as of yet, but it includes UAB. So for those of you who take care of IVAT patients or patients who inject drugs at UAB, this could include your patients. And what we're learning is that of these opportunistic infections with injection, a majority of the bacterial infections we're seeing are skin and soft tissue, bloodstream infections in the yellow, bone and joint in the light green, and then endocarditis 14% in hunter green. Again, we should not see this in young, healthy people and carries a huge morbidity and mortality. And then also we can't forget that HIV is common. About 8% of patients who inject drugs that make it to our hospital for bacterial infections may have comorbid HIV, and 40% have hepatitis C across this choice study. I should say at UAB that percentage is more like 70 or 80% have hepatitis C. We definitely have a disproportionate burden of that here in the Deep South. So remember, in addition to these bacterial infections, when you're taking care of these patients, you can give them prophylaxis, right? Just like our HIV-infected patients may meet criteria for prophylaxis, our patients need prevention too. They need hepatitis A vaccination. They may meet criteria for HIV prevention through PrEP. So remember these when you see these patients. The second tenet here, and I did cross out some of our HIV lessons to make them more relevant for addiction. So we're taught HIV treatment is HIV prevention. So you may have heard treatment as prevention. And what I mean by that is that if we can treat your patient's HIV and get their virus undetectable, we'll prevent them from spreading that to their sexual partners they may share drug use materials with. So HIV treatment is HIV prevention. But what we've learned is that with addiction and opioid use specifically, addiction treatment is HIV prevention as well. So if we can get our patients' addiction under control, if we can get them to quit injecting and these other high-risk behaviors like transactional sex, we can prevent HIV and other infections. So we have 3 FDA-approved meds for opioid use disorder. You may have heard of buprenorphine as part of Suboxone. You probably have heard of methadone and maybe even naltrexone, which is also known as Vivitrol in terms of the trade name. And what's important about these 3 medications is that they reduce the amount of injection drug use, other high-risk behaviors. So they prevent HIV acquisition. They keep your patients from getting HIV. And if your patient has HIV, these meds keep their virus, allow them to take their meds, get their virus under control, and prevent spreading hepatitis C and HIV. But because they reduce the likelihood that your patient is injecting, they also prevent endocarditis. They prevent skin and soft tissue infection. So really, it's important to remember that addiction treatment is infection prevention. And I would also say for patients that use other substances, not opioids, maybe meth. Meth is also a huge problem for us. Think about getting them involved in addiction care as well, because even if they don't qualify for an opioid use disorder treatment, they'll qualify for additional services. And this is just some additional hospital data showing you here in the green box that buprenorphine, it increases the chance your patient will complete their antibiotics by 15-fold. So here again, treating opioid use disorder helps your patient complete their antibiotics for their osteomyelitis, for their endocarditis. Similar findings with methadone, just not as potent. And then if your patient, again, does not meet criteria for opioid use disorder, maybe they have meth use disorder, maybe they have cocaine use disorder, maybe they're injecting another substance. But if they get an addiction medicine consult, so they qualify for that consult, even if they don't qualify for pharmacotherapy, we increase the chances that they will complete their antibiotics, that they will receive appropriate pharmacotherapy. So addiction treatment, whether it's pharmacotherapy or consultation, can improve infections. Another really important lesson is around readmission. We know these patients are frequently readmitted. Again, very similar to our HIV infected patients, very vulnerable. If we can get them addiction medicine consultation in blue, we can keep them from being readmitted over time. Whereas if we don't, the likelihood that they're going to be have a readmission-free survival over 100 days declines. So get these folks in care. Next, we're going, I think I went the wrong direction. Oops, sorry. Next, another principle that we learned is that rapid treatment matters. So you may have heard of rapid start HIV treatment or antiretroviral therapy. We know that starting our patients on HIV care as soon as possible reduces their virus, right? And reduces the chances they'll spread HIV and reduces their morbidity from AIDS-related complications. Similarly, we need to be thinking rapid start towards opioid treatment. We saw that at the beginning, right, with overdose fatalities, but other chronic comorbid infections like endocarditis, HIV. So starting our patients on therapy early is really important. Here's some data on why. We know that patients who inject drugs at UAB have poor hospital outcomes. We know at UAB specifically about 34% use drugs in the hospital, 11% leave AMA against medical advice, which we try to use the term patient-directed discharge because it's more patient-centered. So they're highly likely to elope or leave early. 14% are readmitted. And of the ones that we found with help from Dr. Brandy McCluskey, of the ones who we found through coroner and forensic pathology reports as deceased, I mean, they represented about 10% of our population within 3 years. We know that more of them are deceased. We just don't have a great way to survey that data. So these outcomes are all really horrendous for hospitalized patients. So this is why I'm encouraging you for any of the touch points that you all have in the hospital, or if you're doing research in this space, that we really have to think of ways to reach these patients rapidly, just like our HIV infected patients who are also very hard to reach. We have to reach them rapidly and get them on treatment. All these outcomes are preventable with meds for opioid use disorder, like buprenorphine, like methadone, and the addiction medicine consult over here too. Remember to get our addiction colleagues on board. And then other resources that we've learned from the HIV world, we know social work, we know intensive case management really help us reach our patients with HIV, very similar for our patients with substance use. And I also want to bring up this term, a peer recovery coach, which we've used in the HIV world. This is someone with lived experience. So for HIV, we may have patient navigators or coaches who have HIV, who've been successful with their treatment, who may help our patients navigate the system. That's another tenet that we've learned from HIV, and we're applying in addiction treatment, knowing that patients who've recovered from heroin use, meth use, alcohol use, those types of staff are very helpful in linking and retaining our patient in addiction treatment. And that's a resource we have at UAB. So if you work at UAB in the clinical space, you can actually page and have a peer recovery coach help your patient with addiction. And sorry, I'm blowing through this. I just want to give us plenty of time for Dr. Elopre as well. More data just showing the importance of rapid treatment. So here, this is another hospital-based study by Dr. Josh Barocas, who's at BU. But basically what he showed is if we can get people on meds for opioid use disorder within 30 days of hospital discharge, we can reduce their overdose rate over a year significantly. And we can also reduce readmissions over a year. That's just by linking people to medications for opioid use disorder quickly after discharge. So primarily buprenorphine or methadone. So again, that's rapid start treatment, whether it's HIV treatment or opioid use disorder treatment. All right, and lastly, I just wanted to use the opioid care continuum as a reminder for not just HIV care, but really many chronic diseases. We've used this to identify the best metrics to get and keep our patients in care. And for opioid use disorder, that is no different. What we know about HIV is that in order to standardize population health and help countries and communities get their HIV burden under control, we need to rapidly identify people, universally screening in certain situations like UAB hospital, other hospitals. We need to get people on HIV treatment. Ideally, 90% of those that are identified will be started on treatment. Well, ideally 100%, but we use 90% as our metric. And then we want to get at least 90% of those who are on treatment virally suppressed. So that's the 90-90-90 goal that you may hear often as a goal for Alabama, but also globally to end the HIV epidemic. And this has been really inspirational for the opioid treatment space. I will say that opioid treatment's a little different because not everybody needs to be on methadone forever. So they can go in remission, unlike HIV, right? We have no cure for HIV. You got to be on ART for as long as you live, unless we have a cure. For opioid use disorder, it's a little different. And there's also a lot of other things we can do for opioid use disorder because we know about 60% of people will fall out of care within 6 months. So this is a cascade I created just based on some of my observations really with treating patients with HIV and opioid use disorder. We know that millions of people are at risk for opioid use disorder due to musculoskeletal injuries, low back pain, athletic, football-related injury. They get prescribed high-dose opioids and end up at risk. The goal is to identify them through screening in routine care settings. It's recommended for all adults be screened for this, diagnose them, get them engaged in treatment. So again, buprenorphine and methadone being the preferred treatments. And then I added this as really key for our patients. We often don't remember things like Narcan, which is an essential part of their care. We know that even if we get them on buprenorphine or methadone, a lot of patients struggle to be retained in care. So sending them home with Narcan for harm reduction is really important. Another goal to keep them engaged in care. We know that people that are engaged in opioid treatment for at least 6 months are much more likely to have long-term success. And then the goal is for them to stay in remission. We know that most people need 5 or 6 efforts to stay in recovery. So knowing that your patients are going to have this really roller coaster ride, and you should expect them to fall in and out of care. And we, just like in HIV, we have an open door policy. They're always welcome to come back whenever they're ready to get started on treatment again, whether it's a Monday or a Friday, or whether we've seen them in 5 days ago or 5 years ago. So that's really important and something we've also learned from HIV care. And then my last slide, I just wanted to show you all how we're doing at UAB, because I know a lot of you work at UAB and conduct research there. This is work from our intravenous antibiotic and addiction team, which includes an addiction medicine consultant, ID consult team who help with antibiotics for folks like those that I mentioned at the beginning with bone and joint infections, endocarditis. We have a lot of work to do, so I left this as our kind of inspiration for moving forward. We know that of about 98 hospitalized patients who inject drugs, about 80 of them identify their drug of choice as opioids, so they met criteria for opioid use disorder, but a small percentage of them, less than half, were started on appropriate treatment. If this were HIV, that would be unacceptable, right? If we had 80 patients diagnosed with HIV in the hospital and only sent 40 home on antiretroviral therapy, that would be unacceptable, and it's really unacceptable. There's lots of barriers. It's not just on the provider end. Some patients are not ready. Some patients have trouble getting access to medications due to insurance issues. So lots of barriers. But because I'm talking to you all, I want to inspire you to think about barriers on your end, that we can really discharge everybody on appropriate treatment, much like we do with our linkage and retention team that sees patients with HIV in the hospital. We really should be doing a similar approach to our patients with opioid use disorder. So just in summary, remember that opioid use disorder leads to a host of opportunistic infections. Remember, addiction treatment is HIV prevention, it's infection prevention, helps with infection treatment. Start meds early, get addiction treatment team involved early. Know that opioid use disorder treatment is essential. And if anybody's interested in getting their X waiver to prescribe buprenorphine, that policy has changed and is relaxed a fair amount. So please reach out to me if you have any questions or concerns. And just wanted to thank my whole team, including Dr. Saag, one of my mentors.
Thank you so much, Ellen. This is very, very interesting. In the interest of time, we'll move on to our third speaker, Dr. Elopre. She is going to talk to us about social determinants of health in STDs and HIV. Latesha is also an assistant professor in infectious disease, and we're also very, very excited that she accepted to be part of this great team.
Okay, thank you so much for having me. So I'm calling from Florida right now on vacation, but I wanted to talk today because this is just so amazing that we're at this pivotal moment. We're at the 40th anniversary of the first case that was published by the CDC. And so I'm really focusing on discussing how HIV and this epidemic domestically has affected vulnerable communities, and specifically Black communities that are in the South. This is, make sure I can advance. Here are my disclosures. So to begin, I usually start my talks by focusing on this article that I really thought was groundbreaking in 2017 by the New York Times that shed light on what they called was a hidden epidemic, talking about the fact that Black gay men, especially Black gay and bisexual men living in the South, were carrying the burden of the epidemic. And the reason why it was so powerful for me specifically is because I actually had a family member that passed away from HIV in 1992 at the age of 28, a young Black gay man. It was the reason I became a doctor. And unbeknownst to me, I didn't know at the time when he passed away that he had HIV and that's the reason he died, or the fact that he was gay. And I think that as I've evolved as a physician scientist, I understand now that this is really the main barrier to people accessing care. You know, you think to yourself, if he had made it to 1996, maybe he would have had highly effective antiretroviral therapy and that would have allowed him to survive. But the truth of the matter is, it's that stigma and other social determinants of health that keep people from accepting their sexual identity, structural barriers that keep them from being able to access care, are the reasons why we're currently seeing pandemics and epidemics affecting these vulnerable communities. So, and, you know, in this article, seeing a young man in Mississippi standing on a rural road by himself, really carrying the weight of the epidemic on his shoulders, I think speaks volumes to the fact that we know that highest rates of infection occur among this group of individuals, as well as Latinx, gay and bisexual men who have sex with men, and Black women. So what I decided to do with my career, I think a lot of people have focused on, is how can we prevent people from getting HIV, right? So we know that, unfortunately, due to health inequities, if you become infected with HIV, if you are Black, Latinx, or one of those vulnerable communities that I previously talked about, your risk of having poor outcomes, not being able to attain viral suppression, is higher. So the goal should always be prevention. And HIV pre-exposure prophylaxis is a pill that you can take once a day. And if you use it consistently, it can reduce your risk of getting HIV if you're exposed by up to 95%, and for cisgender women up to 92%. But what we're seeing is that there are huge disparities in who is getting PrEP. So the CDC predicts that 1.1 million people right now have an indication for PrEP, the majority of which are Black, gay, and bisexual men who have sex with men. But that's not who's getting prescriptions. And if you look at it over time, this data is actually a little old. If you look at the most recent data that we have, these numbers have slightly improved, but the majority of people getting prescriptions for PrEP right now are white, gay, and bisexual men. And then the group who's least likely to get a prescription are Black cisgender women. And so the question is why? Why are we seeing these disparities? And something that really could be groundbreaking and end the epidemic. The other barrier that we're seeing is that it's worse in the South. The South has some of the highest PrEP to need ratios, and we know from stories in other locales of the country, like the West Coast and Northeast, when you have high utilization of PrEP, they've been able to almost, drive their rates down to nothing. And we aren't seeing that in the South. We're just not seeing PrEP use. So what I've been working on is trying to understand, talking to Black communities in general, what we can do to improve access to PrEP. And I did one group that focused primarily on young Black, gay, and bisexual men who have sex with men, recognizing that this group is the group that's most likely to be impacted. And a lot of the questions I focused on talked about their lived experiences and how that was a barrier, how their specific life stories could help us gain light into how we could prevent HIV infection. And what I found, which wholly makes sense if we understand how communities work, is that it's not just Black gay men, it's the communities in which they live and the relationships that they have with all community members, especially within Black communities. So these are some stories that I was able to share that I thought were just really impactful. So this young man said, I think that's why people have risky sex, really. Without them knowing it, they're trying to act out the validation that they don't get from people who they feel they should get it from. This young gentleman said that he felt like he had to hide who he was, and that the fact that he was not getting acceptance when he goes to places like the healthcare system hurts him even more. It makes him afraid to get tested. It makes him afraid to access services. And he asked at the end, where do we find that community? And then one person talked about how he came out to his grandmother, and that when he came out, he got just a level of acceptance he wasn't expecting. He said that she just hugged him. She said, Jesus still loves you. I still love you. Do your thing. And what this really led me to understand is that if we're talking about ending the epidemic, especially in vulnerable communities like Black communities, we cannot just focus on an individual. We can't just focus on young Black gay men, because they have relationships with friends, families, and significant others. So we have to attack it at multiple levels, the interpersonal level, look at the communities in which they live as well. And this is, I think, where most HIV prevention work is going, trying to understand on multiple levels how we can improve outcomes for our most vulnerable populations. And with that led me to shift and not just focus on Black, gay, bisexual men who have sex with men. I'm still doing that work, but also talk about a group of individuals that don't have as much research, and that's Black cisgender women. How can we improve PrEP among this group? And then have studies that not just focus on one individual, but these relationships that we know that are strong and affect your behavior in communities. And this is just data that's really showing you why. If you look at this data, you can see that among PrEP users right now, women are the ones who are getting the least prescriptions for PrEP overall. And so thinking again about this idea with intersecting disparities, looking at multiple intersecting identities that are stigmatized. So being Black, potentially living in poverty, the stigma you have from being a woman, and just being within the Black community, hearing their stories and understanding how to especially and specifically design interventions to improve uptake among Black cisgender women. The barriers that have been identified already have been really on multiple levels, on the individual level, the community level, and these barriers, what I think is interesting, are not just for Black cisgender women, it's for Black gay men as well. So there's low overall awareness that has somewhat improved, but knowledge about how to access PrEP is still lacking. lots of medical distrust, concerns about cost and safety. No one thinks they're at risk for HIV. And I think that also has shifted our discussion from not just focusing on risk, but talking and using more empowering language when we're talking about prevention. Stigma related to HIV and PrEP is huge. And then people talked about the fact that having a support system within their community and with their peers has been the main thing that has allowed them to access prevention services. And so this is, again, I love qualitative work. This is a group of interviews I did with Black cisgender women. I specifically focus on urban and rural settings in that Black Belt region that we have across our state. And stigma came out loud and strong. Stigma, knowing that you've got to be taking this pill to prevent something that's out there. If you have to go into a certain clinic, will someone see me? And that was from a woman who lived in Jefferson County. And then a rural woman said, another concern I have about it is, with this medicine, is it just, for lack of a better term, is it geared just towards African Americans? Is it like we're the only ones? You're a guinea pig. And I picked this specifically because I think it's also relevant to what's happening with the COVID pandemic and vaccine hesitancy, as it were. So when we're looking at how we're going to improve access to PrEP for women and for men, a lot of people have also, understanding that we need to focus on population health, have tried to do consumer-facing interventions as well. Actually go to Black women and Black gay and bisexual men and say, what do you want? What service delivery package would be most attractive to you? And I was able to do a study using discrete choice experiments, which Dr. Eaton has experience with, where you literally do something called behavioral economics, trying to understand what service delivery package would be most attractive, what attributes matter. And what women specifically said, and this is not surprising, is that they don't want to go to ID doctors to get PrEP care. ID, unfortunately, because of stigma related to HIV, no one really wants to be seen in our clinics. And so they want to go to their gynecologist. They want to go to someone that they already trusted, that they wouldn't be disclosing the fact that they were getting PrEP from by accessing care with them. They were interested in other modalities that prevented them from having to take a pill every day, that reminded them that they were taking something to prevent HIV. So long-acting options that hopefully will get FDA approval soon were very attractive to them. And then, especially in the rural area where we did latent class analyses, they wanted teleprep. They didn't want to even go into anybody's office where there was the concern that they could be seen by their friends and their loved ones, because that community impact and our cultural norms matter. And so the aspect that I think we're moving towards, which I'm very happy about, we're looking at multiple levels when we're talking about interventions. How can we improve the individual, their interpersonal relationships in the community? What we haven't done a great job of is looking at other levels in that social ecologic framework. So how can we improve our healthcare systems and look at public policy? Because when we're talking about the hugest barriers, understanding that things like systemic and systematic racism and the impact it's had on Black communities and Latinx communities and other vulnerable communities out there, that's going to be the end game, because no matter how empowered you get somebody to access care, if they're not able to actually go to a doctor's office because they don't have insurance, they don't have transportation, then it's all for naught. And so I want to end with this. There's a study that I'm hoping I will get my NOA for soon that focuses on this concept is social capital. So how can you go into a community and say, we are all lacking when it comes to sexual rights and HIV prevention. And with that, we're going to use our shared resources to overcome these barriers. And the best example of social capital is the civil rights movement, which I think is beautiful because this is really born in the state of Birmingham, Alabama, right? So the civil rights movement was people using their social capital to overcome an injustice. When people lacked, and they were doing the Montgomery boycott, they lacked transportation, they shared rides. People weren't able to get to jobs and they lost their jobs due to discrimination, racism, or violence. You know, people open up their homes, and that's the kind of social capital that I think is going to be necessary for the most vulnerable communities to access things like HIV prevention, push for policy change, and become social activists. So that's really what I wanted to focus on for this 40th anniversary. I hope that as we move forward, And it looks like it is with the great people who here at Birmingham doing great research and the community partners that we have, that this is all going to get better and things will continue to move forward. I wanted to give a special thanks to the community-based organization that I've been working with, Medical Advocacy and Outreach, and all the participants. And then, of course, all of the wonderful scientists I get to collaborate with at UAB. So thanks for letting me speak.
Of course. Thank you so much, Latesha. This is fascinating. Dr. Saag is coming back to wrap up this wonderful session.
Yes, I'm going to try to go without video so that I won't phase out, but I do want to make some comments about the parallels between HIV, lessons learned, and what we're experiencing with COVID. I mean, obviously, both are pandemics that involve a transmissible viral infection. But the way that this played out, if we just focus on COVID for a minute, and you think back to what I talked about in terms of the years, not days or weeks or months, years that went by between the identification of the virus, development of treatments, testing, et cetera, that's in striking contrast to COVID, which was first described in December of 2019. The virus was identified about that time. Its sequence was published on January 10th, 2020. Within 2 days, the NIAID, Fauci's group, identified the spike protein construct for the first mRNA virus vaccine, which turned into be the Moderna vaccine. Pfizer, working in parallel, designed a very similar vaccine. The test was available. We didn't deploy it well in the United States, but it was available by late January, early February. The first treatments were tested and released on the first part of May 2020. That's roughly 4.5 months after the virus was discovered and the sequence produced. We now have a vaccine that is widespread throughout the world. And this all happened within a year's period of time from the first announcement, and we still don't have an HIV vaccine. So what this represents is an amazing triumph of science that I would say happened in large part because of the scientific efforts against HIV. Now, there were other viruses that came along that also augmented this, like the Ebola virus and other outbreaks that we dealt with, but nothing prepared us quite as well as our work on HIV from 1981 till today. And I think that's something to celebrate. The negative side, unfortunately, is that the activists for the HIV community were challenging. They did challenge the status quo, but they did so in a way that was trying desperately to move science forward. And they understood, they were making themselves into scientists, and they were participating in helping to get drug development and helping to make drugs available quickly. In fact, it was the activists of HIV that created what we knew then as a parallel track, and now we know as early use authorization. That's the activist community actually helping. In COVID, I'm seeing the activist community actually hurting our efforts. They're spreading disinformation. They have their own, sometimes political, sometimes religious, sometimes other agendas, where they are creating havoc in the world around us. It's making it difficult for us to contain the pandemic the way that we would like to contain it, or the way we know we need to. What's on the horizon for COVID? Right now, we've got things mostly under control for the vaccinated individuals. For unvaccinated people, they remain at risk. I think what we're all concerned about is the Delta variant, which arose originally with the Indian explosion of cases in April, and now is very prevalent in Great Britain and is becoming more prevalent in the United States, such that by September, it's estimated that the dominant variant in the US and in Alabama will be the Delta variant. What that means is that this virus is about 60% more contagious and is more virulent. And so for the vaccinated people, there'll still be protection. But for the unvaccinated, which is about 70%, 65% of our population in Alabama, they remain vulnerable and they can carry the infection. The final point is the other difference with Delta variant is that it attacks young people with disease more than the original SARS strain. And so you'll see young people under the age of 12, under the age of 10, who are becoming sick with COVID, where we didn't see that so much in the earlier epidemic. So I think that's driving us to really push for vaccination of younger people. Now we have 12-year-olds and older who can become vaccinated. We anticipate by September that 5-year-old and above will be eligible for early use authorization vaccine, and above the age of 2 before the end of this year. I encourage everyone to keep up with that. Vaccinate your children, vaccinate yourselves, your loved ones, and do the best we can to put a wall around this epidemic with vaccination efforts. And I'll close there.
Thank you so much. The three of you were outstanding, and nothing less, much more than I expected this to be. This was just fascinating. I would say the sad thing is that we still don't have, we still have so many challenges with HIV, but at least there are so many people like you working on, and we really, really appreciate that. We have a minute for comments or questions from anyone. I like to keep it within the hour, so please ask. There were some comments in the chat. The chat just disappeared. Anyway, if there are no comments, I want to remind everyone that Jessica Snyder sends the invitations for all these sessions, and we don't have anything planned for July and August, but we will come back in September. And Ginger Duncan, who is also a pathologist at UAB and is here with us, is working with the Gender Health Clinic. We want we're gonna have sessions, probably more than one, on gender issues. I don't want to put Ginger on the spot because I forgot to ask her ahead of time, but if she wants to say anything, by all means. We think that transgender issues are very important to talk about in this forum as well. So do you want to say anything, Ginger?
I don't really have anything prepared right now. So.
But you will be you'll all be receiving invitations. If you're not receiving them from the Office of Diversity and Inclusion, send an email to me or to Jessica Snyder, and then you'll receive them. But no, our plan is to continue to offer these very informational and inspiring sessions once a month, September, October, November, and so on and so forth.
Done with my subculture just in time.
And so thank you again, everybody, for participating. Thank you. Mike and Latesha are on vacation and still joined us. That's wonderful. And have a good afternoon, everybody. Thank you.
Thank you.